Okay, hello and welcome everyone to tonight's webinar on antidepressant medication stewardship. Before we formally start, we would like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. I'm Dr. Leonie Harcourt, a GP Education Advisor at the Capital Health Network. Also with me tonight is Kanal Mahiti, the Events Lead at Capital Health Network. And of course, we're very lucky to have our presenter, Dr. Mark Horowitz, back with us again. And if you did not catch his first webinar on deprescribing antidepressants, you can find it on the Capital Health Network YouTube page, and it's well worth a watch. So, as many of you tonight may be aware, Australia has the highest rate of antidepressant prescribing worldwide. The 2021 National Study of Mental Health and Wellbeing estimated that 5.9 million Australians were living with either anxiety or depression, and just over half that number, 3.5 million, were prescribed antidepressants, with 85% of antidepressants initiated by GPs. So tonight we have the opportunity to reflect on these findings and explore evidence of medication class safety and efficacy. And just to flag for Health Pathways, which has lots of pages on the management and referral pathways for many mental health conditions. And also to mention that Mark is happy to field questions at the end of his presentation. So please, if you have any questions, type them into the question and answer box on the Zoom window and we'll read them out and have a bit of a discussion after he's finished his presentation. And now over to Mark. Mark is a clinical research fellow in psychiatry in the National Health Service in England, a visiting lecturer in psychopharmacology at King's College London, and a trainee psychiatrist. He has a PhD from the Institute of Psychiatry at King's College London in the neurobiology of depression and antidepressant action. He is the lead author of the Maudsley Deprescribing Guidelines, which provides the basis for national guidance in the UK from the NHS for prescribers on how to safely stop psychiatric drugs, and has been endorsed by the RACGP in Australia and the Royal Pharmaceutical Society in the UK. He co-authored the recent Royal College of Psychiatrists guidance on stopping antidepressants, and his work informed the recent NICE, so that's the National Institute of Clinical Excellence, guidelines on safe tapering of psychiatric medications, including antidepressants, benzodiazepines, and Z-drugs. So over to you, Mark. Thank you very much for coming back tonight.
Thanks very much, Leonie, for inviting me again. I've just got to apologise. I've got a bit of a sore throat here, so apologies if I've got a bit of a gravelly voice. I've got lemon and ginger tea going hardcore in the background. I'll share my slides, and someone can confirm that you can see them. I'm going to go to this.
Yeah, we can see them. They're not quite on presenter view though.
Get into this.
Yeah. That's it.
Apologies
Thanks.
if I keep on coughing.
Yeah.
Okay. So as Leonie said, I gave a lecture a few months ago on how to safely stop these drugs. And of course, probably a more important issue is when should we start the drugs? People who don't need to be on the drugs are not on them. We don't need to worry about stopping them. And I think that more discerning prescribing is important. I want to kind of give you a broad overview of depression, its natural history, what antidepressants do, some of their issues, to kind of give a broader perspective of things, because I think there's been a lot of messaging for years from drug companies and academics that are paid by drug companies about how safe, effective, and easy to stop these drugs are, which I think has been misleading in lots of ways. So the context for this talk is, as Leonie mentioned, 1 in 7 adults in Australia use an antidepressant each year. It's about 4 million. Something happened?
Yeah, we just lost you.
Sorry. Am I back?
You're back. You're back.
Okay, something shut down. Okay. The prevalence is rising every year. I think we're the second highest user of antidepressants in the OECD. I think we're beaten by Iceland. Maybe that's been, maybe we pipped them to the post in the last couple of years. In Australia, 2 antidepressants are in the top 10 most prescribed drugs, escitalopram and sertraline. 92% of prescribing of antidepressants happens in primary care. Women are more likely to be prescribed antidepressants than men by quite a large margin. Older people, twice as likely as younger people. The average duration of antidepressant use in Australia is 4 years. most guidelines recommend 6 to 12 months of use for anxiety or depression. So a lot of people are using them for longer than guidelines recommend, and we'll come back to whether the guidelines are based on good evidence or not. And many, many people, as I discussed in my last lecture, and I'll mention again briefly in this lecture, find they can't stop the drugs. Um, I I know the story in the UK better than in Australia, although I grew up in Australia. I think something similar happened in Australia, but I'm going to give you the UK story to a bit. I think it will reflect a bit what happened in Australia. But in the UK, how did we end up with so many people being prescribed drugs? Similar numbers in the UK as in Australia. There was a specific campaign run called Defeat Depression in the UK, and I think there's been similar things in Australia. This ran for more than a decade, the 1990s and 2000s. It had two main messages. Feeling miserable, hopeless, despairing is a medical illness called major depressive disorder. And people should see their doctor about this, as there are effective treatments. And this was presented to the public on TV, on billboards. They had cooking shows on TV. They had all sorts of events. It was presented by the Royal College of General Practice in the UK and the Royal College of Psychiatrists. They did a bit of research because the uptake of the messaging was slow, and there was two major blocks from the public. The public believed that feeling miserable, hopeless, and despairing is caused by life problems like divorce, job loss, and physical illness, not a disease called major depression. And they also believe that any medication that affects mood will be dependence forming and difficult to stop. And so the campaign pivoted to try to overturn those two blocks. And they came up with these slogans: depression is a medical illness like any other, like diabetes. And they also said again and again, antidepressants are not dependence forming and will be no trouble to stop. They repeated that line again and again. And over the 10 or plus years, the campaign was successful in many respects. The depression was widely accepted as a medical illness, and rates of antidepressant prescribing soared several fold, from less than 3 out of 100 people before the campaign was run to closer to current levels, 1 in 6. The campaign was actually funded by the major antidepressant manufacturers, AstraZeneca, and other British manufacturers, and it was a very, very worthwhile investment for them. Of course, we're sort of past that now, where illness awareness doesn't require drug companies behind them. It's self-perpetuating. Of course, you can see social media. There's been a similar push with ADHD, of course, recently, because while antidepressants are off patent from the drug companies, the new stimulants, things like Vyvanse, are on patent, and that's why there's been a big push on ADHD, and that's why it's sometimes the advertising says, it sounds like depression, it looks like anxiety, but actually it's ADHD. They're trying to displace the old diagnoses for a new diagnosis accompanied by a drug on patent. And I want to talk a little bit about why the public was actually correct in its ideas that depression is mostly a reflection of life circumstances, and antidepressants are dependence forming and are not easy to stop, and why the misinformation that has been spread through our society has caused so much prescribing. So the origin of all of this is the DSM-3. In Australia, we use the ICD and the DSM. There are similar patterns in the history of these, in the development of these texts. I think the DSM-3 in 1980 was a very big turning point in the history of psychiatry, and I think also in the history of society, because this is the diagnostic manual that psychiatrists use that filter through to GPs and the wider public. In the earlier editions of the DSM, DSM-1, DSM-2, mental health conditions were characterized as reactions in different chapters: psychotic reactions, depressive reactions, anxious reactions. The reactions were to events in life. In the 1970s, psychiatry was under attack as not a real medical specialty. Psychoanalysis was the driving force in psychiatry at the time. It was seen not as solid science. And DSM-3 was psychiatry trying to establish its credibility as a medical specialty. And so it shifted to a disease model like other medical specialties. And so it translated depressive reaction into major depressive disorder. Anxious reaction became generalized anxiety disorder. People think that these diagnoses must have been backed by a lot of science, a lot of research, imaging, biochemical assays, but actually it was a decision in the 1970s by a group of psychiatrists in America who wanted to make the conditions that they treated sound more like medical conditions with greater legitimacy. It was not based on new research or new findings about the brain. The members of this committee, the DSM-3 committee, have been interviewed on the process, and they said things like there was very little in the way of data. They thrashed things out. They decided most things based on a vote. So it was clearly a social process. They said things like that having 6 symptoms to diagnose depression was too many, 4 seemed too few, so they decided on 5 symptoms. Other people on this committee said things like, we decided not to include that symptom because a member of the committee experienced that, and that was thought to be normal, therefore. One of them described the process as like a group of friends deciding on where to eat dinner. One would suggest Indian, one would suggest Turkish, and they would compromise on Chinese. And they talked a lot about the long discussions they had, hashing things out through argument and eventually through a vote. Alongside that, I think in the UK, PHQ-9 and GAD-7 are the most commonly used diagnostic tools for depression. I think in Australia you use things like the K10, but these PHQ-9 and GAD-7 were actually written by Pfizer in the 2000s. You can look at the bottom of any one of these forms and see Pfizer's copyright bottom. It's been compared to the introduction of pain as the 5th vital sign in America, which was a way of encouraging doctors to prescribe more pain medication. And these sort of diagnostic tools can act to encourage doctors to prescribe more, because if you give someone the test, they meet a certain threshold, you feel a compulsion to do something to treat what they've presented with. And so these things can push clinicians to prescribe more because they're diagnosing more. I want to talk about what causes depression. For many years, the public, and that includes clinicians, have been told that antidepressants work by rectifying an underlying chemical imbalance, normally said to be low serotonin. And that is often translated to patients as antidepressants for depression is like insulin for diabetes. This was initially a scientific hypothesis in the 1960s. It was coined by Schildkraut, an American psychiatrist. There's been a lot of research for the last few decades, but the hypothesis really became amplified in the 1980s and 1990s by the drug manufacturers. Because, of course, if you believe that depression is caused by low serotonin, then a drug like an SSRI that increases serotonin sounds like a very sensible, very effective treatment. And that's why that hypothesis, out of all the hypotheses in medicine, has become such a widespread idea, because it had a lot of money behind it. In actual fact, 6 decades of research since this was coined in the 1960s has found no robust evidence of a difference between depressed people and healthy volunteers in serotonin, noradrenaline, dopamine, any major neurotransmitter. We conducted an umbrella review of all existing data looking at serotonin in people that are depressed and healthy volunteers, and we published that now 3 years ago in Molecular Psychiatry. We looked at everywhere you could, any study that looked at serotonin in body fluids and cerebrospinal fluids, looking at receptors in the brain, transporters, genes, ways of depleting serotonin by giving people food that doesn't include the amino acids you need to make up serotonin. And what we found was, to summarize a long paper, that there was no evidence the genetic studies were convincingly negative, or the genes that control serotonin. And these all found very strong associations between adverse life events, things that stress people out, and depression, rather than all of these biochemical findings. The paper that we published, was greeted by the major psychiatric institutions as boring, as we already knew that. This is not news. So the Royal College of Psychiatrists in the UK has said the old idea that antidepressants correct a chemical imbalance in the brain is an oversimplification, and we do not support this view. They've removed discussion about low serotonin or chemical imbalances from their leaflets, their website. The same is true for the college in Australia. It's removed mention of chemical imbalances of low serotonin from its website and messaging. Same in America. And a prominent US professor of psychiatry has referred to the chemical imbalance as a kind of urban legend, never a theory seriously propounded by well-informed psychiatrists. He's described it as a kind of just so story that the doctors use to encourage patients to take their medication. And the APA in America has said that additional experience has not confirmed the monoamine depletion hypothesis. Monoamines being the group of transmitters that includes serotonin. The other thing that came out of our paper being published was that although psychiatrists all said we already knew this is not news, to the public it was a very big shock. This is a measure of attention score to an academic article. And out of 23 million academic articles that have been published so far, this paper has been in the top 300 most shared and viewed papers. So it was a very, very widely shared. And that is because the majority of the public, they've been surveyed in Australia and the US, believe that depression is caused by a chemical imbalance. So this news that that was not the case was a shock to many people. So if it's not serotonin, low serotonin causing depression, then maybe there's another brain abnormality that's causing depression. And there have been a lot of studies over the last few decades looking at neuroimaging, looking at different theories of depression to try to find some biochemical or neuroimaging abnormality that will help mark depressed people from non-depressed people. And I'll just go through those studies now. This is probably the biggest study that's been done recently. 1,800 people were put through every neuroimaging available. MRI, something called diffuser tensor imaging, which helps to image the white matter tracks. It's a very expensive, up-to-date technique that is much more detailed at looking at the way that fibers pass through the brain. Functional MRI, and they looked at a group of depressed people and a group of healthy volunteers, and they found that the differences between the two groups was within the margin of error. In other words, the difference between the brains was less than 2% of variance, and they concluded there was no way to distinguish healthy volunteers from depressed people on neuroimaging. Another paper a few years ago performed a meta-analysis of all the predicted biochemical changes in the major theories of depression. So very briefly, there's an immunological theory of depression that increased inflammation causes depression. There's a neurotrophic theory of depression that BDNF or other growth hormones explain depression, that having a lack of them may be the cause of depression. I've already mentioned, of course, the neurotransmitter theories. There are hormonal theories that increased stress hormone over time affects the hormonal system, and that's what causes depression, or oxidative stress. And this meta-analysis looked at all of the different biochemical markers that you would expect to see different if these theories were true. And they found that none of these theories were supported by studies. There was not changes in immune function between depressed people and healthy volunteers, not differences in BDNF, not differences in serotonin. There was in people that were currently depressed, there was an increase in cortisol. So there was evidence that they were stressed, but there was no changes in long-term functioning of their hormonal system or no differences in oxidative stress. And they concluded that there was not robust findings that would allow us to distinguish healthy volunteers from depressed people, which of course is why there's no blood test or imaging test for depression at the moment. After we published that paper about depression and serotonin, we got a lot of questions about, well, what is it that then causes depression? If it's not low serotonin, then what is it? Is it another chemical, or is it something different? And I think, we do know, and people say maybe we need more research, but I think we do know the answer to what causes depression. And I think that this study, which is now 20 years old, I think captures it well. What I'm showing you here is, let's look at the women's side on the right side. The x-axis is the number of stressful life events somebody has in a given 12-month period. If they have no stressful life events, it's called none in terms of contextual threat. That's the language that this paper uses. If they have more than 10 stressful life events, it's called severe contextual threat, and intermediate is the categories in between. A stressful life event is one of the following: divorce, job loss, moving cities, death of a loved one, diagnosis of a serious physical illness. And the y-axis is showing you your risk of becoming depressed in the 2 months after that 12-month period. And what it's saying is the more stresses you have in your life, the greater the risk that you'll be depressed. And that effect is huge. The difference between having no stresses and having more than 10 is 30-fold in your risk of depression. So the hazard ratio here is 1, and up the top it's 33 or 34. I have not seen a relationship that is that strong in medicine, except for the relationship between number of cigarette packs smoked per year and lung cancer. The different colored lines are about people's personalities. So if you're highly neurotic, which basically means sensitive to stress, the relationship is steeper. And if you're a steadier person, low neurosis, then the relationship is less steep. And of course, in personality is upbringing and also genetics. So there is genetics in this in terms of affecting people's personality, but of course we can't affect people's genetics. And so what this is really saying is the major driver of if someone is depressed is what is happening in their lives. For people that have no stresses, almost nobody is depressed. And people that have everything go wrong in their life, many, many people are depressed. And in fact, depression is a very common experience. I think sometimes you hear things like depression happens to 1 in 4 people, something like that. It's actually much, much more than that. This is a study where they followed people, a random group of people born in a hospital in Dunedin. They followed them for the last 45 years. So this study began, I think, in the 1970s or 80s. Every 5 years, they followed them up and gave them the diagnostic interviews for psychiatric conditions using the DSM as the guide. And by the age of 45, have a guess what proportion had met criteria for a mental illness, mostly major depressive disorder or generalized anxiety disorder. You can have a guess in your mind. The answer was 86% of people met criteria for any mental illness by the age of 45, and 70% of all people met the criteria for clinical depression or anxiety. In other words, most of us, just in the first 5 decades of life, meet criteria for clinical depression or anxiety. In other words, you're more likely to be depressed or anxious in your life than not. And I think the point worth making is it would be very peculiar if 70% of us had an abnormal brain, something wrong with us that made us susceptible to depression. What this story, I think, is saying is depression or anxiety is a fairly common response to life being very difficult, which means when people's ability to cope is overwhelmed, when too many things happen to them at the same time, a very common response is depression or anxiety. It's not a rare thing. It doesn't represent an abnormal neurochemistry or an abnormal brain. All you need is a normal brain and a difficult life to experience depression. And the natural recovery for depression is excellent, is what most studies show. So on the right-hand side is recovery rates for depression without treatment. In the top right, you can see severe depression and mild depression. If you do nothing, at 10 months after diagnosis, 80% of people with mild depression are better, and a bit less for severe depression. It takes them about a year or a year and a half to get down to 70% recovery rates. The graph below, this is true for people that access no care, primary care, or secondary care. So that the natural recovery of depression, and of course that makes sense. When people get divorced, lose their job, they go through a period of grief, they readjust. Sometimes they get into new relationships, sometimes they find new jobs, they accommodate to being unwell, they accommodate to grief or loss. That is the natural history of humanity over the millennia. So this is not all that surprising, although I think most people sort of been led to believe depression is a very severe condition that needs intervention in order to improve, and that's not what the data shows. I want to spend more time now talking about antidepressants and what role they play, what do they do. We've already said if antidepressants do not rectify an underlying lack of serotonin, how do they work? And I've mentioned theories of depression, and along with them, some people suggest that antidepressants neutralize whatever negative changes underlie depression. So, for example, depression has been hypothesized to be a lack of neurogenesis, that is, a lack of growth of new brain cells, and antidepressants have been said to be able to cause the growth of new brain cells. Other theories are antidepressants are anti-inflammatory. They can reduce inflammation. Actually, I did my PhD on both these topics. As I mentioned, in mostly the bit I mentioned was that this was not proven in humans. I've shown you that meta-analysis that finds that the predicted changes in these theories is not found in depressed people. Most of the evidence for antidepressants affecting neurogenesis or affecting inflammation comes from animal studies or cell studies. That's what I did my PhD on in cells. I think the most popular theory about how antidepressants work that's not about serotonin is that antidepressants cause the growth of new brain cells. But this very much took my imagination for my PhD. I did my whole PhD on this topic. It wasn't until I finished my PhD that someone mentioned to me, actually, the growth of new brain cells may not be a positive thing. It may be a sign of damage. For example, the following things cause the growth of new neurons. Blunt trauma to the head, chemical damage, and stroke all cause the growth of new brain cells, in the same way as if you cut your skin, you get the growth of new skin cells. And the other issue is, is more nerve cells, is more neurons a good thing? You sort of think, oh, that makes sense. More, brains are good, so more brain, that should be better. But if you think about bricks in a house, is it better to have more bricks? It is if it builds a second story on your house and increases its value. It's not great if the bricks are in the living room and obscure your view of the TV. So I do think when people sort of tout that a new treatment causes the growth of new brain cells, it's worth thinking, what does that mean? Is that a sign that the treatment might be causing some sort of irritation to the brain that leads to a recovery process, or is it a good thing? And I don't think we're very sure about what the case is when it comes to antidepressants. There is a much more obvious, plausible way in which antidepressants work that is often skated over, and that's emotional numbing or blunting. So when people on antidepressants are surveyed, more than half, and sometimes up to 3/4, report emotional numbing or blunting. They say that their range of emotions, from very positive to very negative, is pushed into the center. It's also correlates with sexual numbing. Genital numbing is a very common effect of these drugs. There's a correlation between sexual numbing, genital numbing, and emotional numbing. In fact, if you chew up many antidepressants, they will numb your mouth slightly. So there does seem to be anesthetic properties to these drugs. For a while, people suggested that, well, it's probably the depression causing this emotional numbing, and these people are just mistaking their depression for the effects of antidepressants. But there was a study done in Cambridge, now a couple of years ago, where they gave escitalopram, the most common antidepressant in Australia, to healthy volunteers and showed that people had profound emotional numbing within 3 weeks of taking the drug, and it impaired their ability to make decisions because it impaired their emotional learning. This effect may provide relief from strong emotions. If you're very anxious, very depressed, or very panicked, having the volume turned down from a 10 to a 3 may be a great relief. But it's also the number one reason that people give for wanting to come off their antidepressants at the clinic that I run in London. People say it affects their quality of life. It affects what they think of their spouse, their children, their interests. And when people come off these drugs, they report these feelings come back. They take up old interests. They feel more themselves. And I think that given that most people in Australia believe that these drugs are correcting some sort of chemical imbalance, people should be told that the most common way, the most plausible way in which we think these drugs work is through emotional blunting. And I think that implicit in that, if people do start these drugs, that is an implicit message to use these drugs for a shorter period of time. If something was like insulin for diabetes, of course, it makes sense to use that lifelong. If it's not, and I don't think that's a legitimate analogy for these drugs, it makes more sense to use them for as short a period of time as possible. if the effect is blunting. I just want to kind of broaden that point a little bit to other drugs for depression and also mental health conditions, because it's a kind of common theme that runs through this area. And people talk about two different ways of understanding the way that psychiatric drugs work in general. One of them is the disease-centered model. This is imported from general medicine, where the way that most modern physical health drugs are correctly understood to work in this way. So, for example, drugs act on an underlying abnormality. They act on the process that causes the disease, and they reverse it to relieve the disease. For example, chemotherapy acts on abnormally dividing cells to reduce the effect of cancer on the body. Blood pressure medication relaxes blood vessels to reverse high blood pressure, and insulin replaces a lack of it in diabetes. That theory has been imported to mental health conditions, and often it's around the chemical imbalance theories that, as I've said already, the antidepressants correct a deficiency of serotonin. It's also been applied to anxiety and many other mental health conditions. But if it's not supported by research, as I've mentioned, there are not brain abnormalities that have been found for depression or anxiety or any other psychiatric condition. And there's also a lack of evidence that these drugs are specific. So you might have noticed in practice that now stimulants, anti-anxiety drugs, antipsychotics are all used in depression. They all have similar effects. Mood stabilizers are used in depression or anxiety. There's little evidence of specificity. That's different from physical health medication. You don't use diabetes medications for high blood pressure. You don't use anticoagulant treatments for stroke prevention in diabetes. These are not the drugs in physical health medication have specific actions, whereas in psychiatry, these drugs have very generic actions and are used across diagnostic categories. So another way of understanding the way that psychiatric drugs worked is called the drug-centered model. The one before, disease-centered, it's reversing the underlying cause of a condition. In the drug-centered model, psychiatric drugs are seen as psychoactive drugs. That is, they cross the blood-brain barrier and they affect the way that the brain functions, and they produce an altered brain state that affects how people think, feel, and act. And in this sense, there's no major distinction between drugs that are used for psychiatric treatment and those used recreationally like alcohol and cocaine, except that the effects of recreational drugs are often pleasant and desirable, but the effects of many psychiatric drugs, particularly stronger drugs than antidepressants, like lithium and antipsychotics, are unpleasant, but also a lot of effects of antidepressants can be unpleasant. And in this model, the effect of the drug could be a great relief. For example, a benzodiazepine causes sedation and relaxation and can be a great relief to someone who's anxious. But the drug is not returning someone to their normal state or pre-symptom state. This is not rectifying an abnormality. The drug-induced state is superimposed on the symptoms that are there and may or may not be preferable to the sufferer, to themselves, or to others. For example, the most obvious example is alcohol. Alcohol clearly, if you have social anxiety, alcohol clearly makes you feel better. You're more relaxed, you're less inhibited. Mild intoxication can lessen social inhibitions. Nobody thinks that alcohol reverses a biochemical imbalance or that social anxiety is caused by an alcohol deficiency. We all understand that there's an abnormal state of intoxication superimposed on the anxious state. And you can think of psychiatric drugs as acting more like that they produce numbing or sedation or euphoria superimposed on top of whatever is going on underneath, rather than reversing an underlying biochemical cause of the condition. And then a number of things then become more obvious. So as for recreational drugs, psychiatric drugs tend to cause tolerance to their effects. Over time, they have less and less effect, or you need higher doses to get the same effect. When you stop a drug, the biological adaptations that arose during treatment are no longer opposed by the presence of the drug, and they give rise to unpleasant withdrawal symptoms. We all know that for alcohol and heroin. We know that more and more, as I talked in my last talk about antidepressants and other psychiatric drugs. It makes sense when you think about them in this model Whereas it can be confusing, stopping insulin does not cause withdrawal effects. So I think this drug-centered model makes a lot more sense. Whereas the disease-centered model assumes that psychiatric drugs help to restore normal brain function, the drug-centered model is stressing that these drugs create an abnormal biological state. The effects might be worthwhile, perceived in some situations. However, they are producing their effects by distorting normal bodily functions and therefore are likely to have adverse impacts, which we'll talk about more specifically for antidepressants. And therefore, these drugs may do more harm than good, especially in the long term. Because I think if you have the model that these drugs are correcting a chemical imbalance, it's hard to understand why they would cause trouble in the long term. Insulin is a perfectly safe chemical to use in diabetes because it's replacing the lack of an endogenous biochemical, but that is not the case when talking about antidepressants or other psychiatric drugs. So briefly to summarize, I won't go through this too much. In the disease-centered model, drugs correct an abnormal brain state. They produce their effects by reversing the underlying mechanisms that produce symptoms. And the examples in general medicine are the way that asthma treatments work, aspirin, paracetamol. In the drug-centered model, more plausible for psychiatric drugs, drugs create an abnormal brain state. The useful effects are a consequence of drug-induced changes to normal brain functioning being superimposed on existing symptoms. An example would be alcohol for social anxiety, or the way opiates work, or the way that antidepressants work by numbing people's emotions being superimposed on whatever issues they have in their lives. So I want to switch here to, all right, let's talk about what do the studies show about how effective antidepressants are in practice. The first thing to understand is I'm going to talk a lot about the Hamilton Depression Score, which is a depression measuring scale out of 52 points that are used in a lot of studies. Translating that into what does it mean for a human being has been done. I want to talk through that for a second. This is a study in which they asked doctors what change on this Hamilton Depression scale corresponds to what level of perceived improvement in a patient. And what they found was that if you have a 3-point reduction in your Hamilton Depression score, no clinician could perceive that. They called it no change. If you had an 8-point difference reduction, clinicians said this person looks minimally improved. 14 points much improved, and 20 points very much improved. And keep that in mind when we look at what the studies actually show. So there have been a lot of randomized controlled trials that compare placebo to antidepressants over 8 weeks. And this is 11 of such studies put together on a graph. I show it because it shows week by week change, so it's easy to see. What all these studies show is basically a 2-point difference between placebo and antidepressants. These 11 studies show a slightly bigger change of 2.7 points. So what you're seeing here is change in depression score week by week. This is using the Hamilton Depression Score, that's the HDRS. You can see that placebo causes a reduction in depression score of 9.5 points, and antidepressants cause an extra 2.7 points. So the effect of antidepressants is about a quarter the effect of the placebo effect. And the difference is 2.7 points in this. Going back to the slide I showed before, 3 points was perceived as no change by clinicians. They required an 8-point difference to say that someone was minimally improved. So even though there's a statistically significant difference between antidepressants and placebo, this is such a small effect that most clinicians would call this no change, and so it can't be seen as a clinically important difference. And it is worth noting that the placebo effect is 4 times as large as the antidepressant effect. This is probably the most famous meta-analysis done for antidepressants. It was done 7 years ago. It was published in The Lancet by a very prominent group in the UK. And this was a study that was widely publicized. And this is an article from The Guardian saying that this study proves that the drugs do work, antidepressants are effective. And I want to go through the study and unpack some of its findings and some of its limitations. So this study looked at 500 studies, thousands of patients, and it found on average as every other study finds, a 2-point difference on the Hamilton Depression Scale between placebo and antidepressant, 1.97 points. Just to say this was not an outlier, this is 6 different meta-analyses, and they all find the same level of change. This is in terms of effect size, 0.3 corresponds to 2 points on this Hamilton Depression Scale. There's also here a line for what NICE considers clinical significance. That's a effect size of 0.5 or a Hamilton Depression Score change of 3. And here is the, from the study I showed you 2 slides ago, there is the change that clinicians think is important, what counts as minimal improvement. And you can see by any judge, the changes between antidepressants and placebo is very small and smaller than what most people would think of as clinically significant. But there are lots of ways in which this study exaggerated the effects of antidepressants. All of these studies were, of course, done by drug companies. There are lots of side effects of drugs: dry mouth, nausea, mental fogginess. People can tell whether they're on a drug or placebo in these studies. We know that expectation effects, so this drug will help me, tend to inflate the effect of antidepressants. People call this the amplified placebo effect. It's not just the placebo effect, but it's sort of kick-started by the effects of the drug. And so in one meta-analysis, when antidepressants are compared with active placebo, so not an inert sugar tablet, but an antihistamine that has a few side effects, the difference between antidepressants and active placebo is even smaller than in the Cipriani study that I've just presented. And there's one study that I think is very illustrative of this amplified placebo effect. This was a study done in the 90s, reported then in 2017, in which they lied to participants. I don't think it'd be ethical today, but they gave everybody in the study an antidepressant who were depressed. But half of the people, they told them they were on an antidepressant, so they were told the truth. And half of them they lied to and told them, we didn't give you an antidepressant, we gave you an active placebo. And they looked at changes in depression scores between the 2 groups. And in the group that was told, oops, I've got this round the wrong way, excuse me. The group that was told it was an antidepressant had a 9.7 point improvement, a much larger improvement than the people that were told it was an active placebo, 4.6 points. What they've done here is isolated the thoughts in people's minds. In other words, the difference between these 2 groups is the expectation effect, about 5 points, which, if you remember, which actually corresponds to 4 points on the Hamilton Depression Scale. In other words, the expectation effects are twice as large as the difference between placebo and antidepressants. So some people argue that the entire effect of antidepressants is explained by these expectation effects and not by any actual chemical effect of the drug. And you can see there is a very large difference here between these 2 groups. The other issue that's been reported on to some degree is publication bias. So drug manufacturers only need to submit 2 positive studies to the drug regulators like the TGA to get a drug approved. That means they can conduct 10 studies, and if 2 are positive, they can just submit those 2. And so what one industrious researcher did a few years ago was to look at the difference between published studies and unpublished studies. So this is the journal version of antidepressant trials. There are 48 positive antidepressant trials. This was 2008, and there was only 3 negative trials. He went to the FDA and he requested all of the unpublished trials that the FDA had seen, which is not all the trials, but it's a larger amount. And what he found was that this picture changed dramatically. There was a very large number of trials that were not positive. So not positive means that there was no difference between antidepressants and placebo. Positive means that the antidepressant was statistically significantly better than placebo, but not clinically important. And even so what he found was 10 studies, because there was 48 here, but now there's only 38. 10 studies had been spun in the publication from a negative study to a positive study, and about 30 studies had been put in the desk drawer, had not been published. And so now, when you look at all the unpublished studies that he was able to get his hands on, it's about a coin flip. The studies are as likely to be positive as to be negative, very different from the published version of trials. I'll skip through this because we're getting on with time. But if you look at the unpublished studies, the effect is about half the size. So if you look at the published studies, the effect is about 2 points on the Hamilton Depression Scale. If you include unpublished studies as well, it goes down to 1 point. So it gets even smaller. Another issue is how long these studies go for. So all of the studies that I've shown you go for 8 weeks. Most antidepressants are prescribed for much longer than this. The average duration in Australia is 4 years. We know that people become tolerant to antidepressants over time, like any drug. The body pushes against a drug that changes its chemistry. And so it's likely to have diminishing effects. So the effects of 8 weeks are likely not to be reflected after 4 years. Sometimes drug manufacturers have said antidepressants don't cause tolerance, but that's not true. Any drug that causes withdrawal effects, like antidepressants do, of course, causes tolerance. That's the flip side. The more tolerant you are to a drug, the more you get withdrawal from it. In America, they refer to tolerance as poop out with their colorful turn of phrase. Looking at long-term antidepressant effects, there are very few studies, but they are not encouraging. There's a 12-month study done by the American government, the STAR-D study. It didn't involve placebo, which is a limitation, but it found that only 3 out of 100 people at 12 months who were treated with antidepressants were in remission, that is free of depression, and had not dropped out of the trial after being tried on a series of antidepressants. There's even some evidence that people on long-term treatment may do worse than on no treatment for depression. There are various hypotheses as to why this might be. It might be because antidepressants negatively affect sleep, concentration, or memory, or they may have a direct effect on mood, which has been called tardive dysphoria, that is late onset low mood. And that is, there is a lack of long-term studies, but a lot of patients report those sort of effects. That's the STAR-D study. This is just very quickly showing what it involves. 4,000 enrolled, 1,500 at any point were improved on various antidepressants, and only 100 stayed well at 1 year. The rest never remitted, dropped out, or relapsed. In other words, the long-term effects of antidepressants are not very encouraging. Another issue that's brought up is, well, we understand that antidepressants are not very effective, for mild depression, and yes, they're probably overprescribed, for life events, but they're very important for severe depression. That's not what the data shows. This is a meta-analysis done by a group of academics who are very close to drug companies. They looked at baseline depression score. So this is using the Hamilton Depression Score. So from 10, so 5 means no depression at all, 10 means mild, 35 means very severe. And they looked at the effect of antidepressant versus placebo on reduction in depression scores. And so for a very low score of 10, the difference is 1.1 points on the Hamilton Depression Score. But even for a Hamilton Depression Score baseline of 35, so this is extremely severely depressed patients, the difference is still only 2.2 points, still below what counts as clinically important or clinically significant. So there is not evidence that antidepressants are more effective for severe depression than mild depression. I've talked a lot about the effectiveness of antidepressants. I want to talk about the adverse effects. There's a long list of adverse effects of antidepressants. There's a lot of serotonergic neurons in the gut, so they cause a lot of gastrointestinal problems. A lot of people get diagnosed with things like irritable bowel syndrome while taking antidepressants because they can cause constipation, diarrhea, or both. In healthy volunteers, they cause sleep disturbances, which has been connected to daytime lethargy and drowsiness. I think sexual dysfunction is recognized. I think the extent of it is not well recognized. More than 50% of people that are given antidepressants have treatment emergent sexual dysfunction, issues with erection, orgasm, desire. There's been a warning put out by the TGA in the last 12 months that some of these effects can be persistent after the drugs are stopped. So a condition called post-SSRI sexual dysfunction, where the issues caused by exposure to the drugs does not go away when the drugs are stopped. There's been different estimates as to how many people are affected by this. The highest estimates are 1 in 7 people exposed to antidepressants. When we don't know whether this is permanent or not, some people report that things improve after several years, What this suggests is that there's abnormalities in people's hormonal system that persist for years after the drugs are stopped. I've mentioned emotional numbing. In younger people, anxiety, increased agitation, and increased suicidality are, of course, there's a black box warning for suicidality in America for people exposed to antidepressants. I'll talk a bit more about withdrawal effects. I talked about that before, but of course, that represents long-term adaptation to the drugs and the difficulty people have when they stop, including these long-lasting effects where people stop called protracted withdrawal effects. I'll put a bit of numbers to this. Often, I was told this in my training, that side effects wear off in a few weeks. And I think a lot of doctors are telling patients that you have some startup effects, they wear off. That's not what studies show. This is a study looking at people who were on the drugs for 12 months. 2 in 3 had at least one significant side effect. 3 out of 10 had 3 or more significant side effects. And you can see in this table, sleeplessness, sleepiness, restlessness, muscle spasms, dry mouth, profuse sweating, sexual dysfunction, nausea, constipation, diarrhea, weight gain, dizziness occurred for between 1 in 10 and 1 in 5 of each of those. There are also rarer but serious issues, fetal abnormalities in women who use antidepressants during pregnancy, especially in the first trimester. There's a 2 to 3-fold increase in heart abnormalities. There are studies that show an increased chance of having social and motor development issues, including things like autism. You can see in animal studies that animals from mothers that are on antidepressants show abnormalities in their social interactions that look like autism. There are signs in human mothers that that fetuses of people who are on antidepressants show different movements in the womb on MRI, and there are differences in their social and motor development a few years after they're born. So it seems to be a long-term impact. Bleeding is better known in older people because, of course, serotonin inhibits platelet aggregation, and that's why we think there's an increased risk of strokes, bleeding after surgery, heavier menstrual bleeding for women, fractures probably caused by both the osteoporosis that antidepressants can cause, as well as dizziness and postural hypotension they can cause in older people. And I've mentioned suicidal behavior in young people, which is a black box warning, at least in America. That's the physical issues, but getting more at the emotional issues, this is a survey of a self-selected population of long-term antidepressant users, people who had been on the drugs mostly for years. So this is not short-term studies done by the manufacturers. And this is what people reported in terms of their emotional and subjective effects on the drugs. Most were emotionally numbed, as I mentioned, feeling foggy or detached, feeling not like myself, sexual difficulties, drowsiness, reduction in positive feelings, suicidality as a result of the drugs, withdrawal effects very common, and addiction, meaning they can't stop the drugs despite wanting to do so. And of course, this is a study looking at people that are long-term users, much more similar than what is happening in England and also, of course, Australia. I just want to talk about alternatives for a few minutes before I give some time for questions. In Australia, I guess you have things like the therapeutic guidelines, you have guidance from the Royal College of Psychiatrists. There is no guidance from the Royal College of General Practice for depression in particular. In England, they have NICE, which Leonie mentioned, the National Institute for Social and Health Care Excellence, which is a government department that is separate from any drug company interests, which is different from Australian guideline committees. So, for example, the psychiatry guideline committees are led by people who work with drug companies. They're academic psychiatrists, but they also work closely with drug companies. That's not permitted in the UK. The way that guidelines are written in Australia is not permitted in the UK. People have to have clear separation between commercial interests, and the guidelines look very different in the UK than in Australia. So I think, number one, before I talk about what the NICE guidelines say, I actually want to take a step back and say, people always ask me, well, if you don't use antidepressants for depression, then what would you do? And I think the answer is you got to try to help the person, the particular problems that they're having. If someone is depressed because of their relationships, because of their housing issues, because of their employment issues, their finances or grief, then that's what they need to be helped with. It may not be easy to do, but an antidepressant that maybe numbs their emotions may get them through a tough few weeks, but it will not solve any of these issues. And so, I don't love being asked, well, what's the one size fits all treatment for depression? Because I think that the word depression obscures the specific circumstances of that particular person, and that's what's important. But I'm always pushed to give an answer, and that's why I'm talking about the NICE guidelines now. So these guidelines break it into treatments for less severe depression and more severe depression. And for less severe depression, they recommend group cognitive behavioral therapy, behavioral activation, a variety of different therapies. Antidepressants are in there at choice number 7, counseling, various other forms of therapy, exercise, mindfulness. Of course, one of the issues is how available these treatments are. And of course, antidepressants are readily available, appear cheap, because all of those side effects I've talked about, all of the withdrawal effects are not priced into the price, the $10 that these drugs cost. And so appear cheap, but all of these other things are as effective and cost effective as antidepressants. And that's also true for severe depression. So here are, I think, 9 treatments for severe depression that are seen as equally effective, and they include treatments that involve antidepressants, this one and this one, but also lots of different forms of therapy that are as effective and cost effective as antidepressants. In fact, it is this treatment down here, individual problem solving, that was deemed the most cost effective treatment for severe depression by NICE. And individual problem solving means you get someone to write down the 3 problems in their lives that are causing them trouble, the first step to take to address each of those problems, and ask them to come back in a couple of weeks to report on barriers experienced or progress made. And I think that really points to the fact that it's the problems in people's lives that drive their mood, and that's why that treatment is so effective. I want to give another specific example because, people say, well, it sounds great to give therapy, but it's not available in my practice, or there's a long waiting list, or it's very expensive. This is a study that was done on watchful waiting. So this is a secondary care center where they looked at 75 consecutive patients presenting with depression, and this is to a psychiatric service. So this is more severe patients than in primary care. They excluded people who were suicidal, and what they provided was general psychosocial advice, depathologization, normalization of low mood as not a brain condition. So they felt that people's belief that they had a brain condition or a chemical imbalance was one of the drivers of poor outcomes, because people became pessimistic, and also a request for medications. And they sat there and decided what they would do with the person. In other words, a very low technical intervention. The intervention didn't involve any therapy and no medication, and it was effective in 2/3 of people at 3-month follow-up. So 2/3 of people who were just told, essentially, this will pass, it's because of things in your life, here are some things you could do in the meantime, come back in less than 3 months, 2/3 of people were better. In part, that's because of natural recovery, people's lives change. In part, it's because of regression to the mean. At the time in our lives when we feel worst, chances are we'll be a bit better a few months later. The researchers found that the expectation from the patient that they should receive medication was the main factor influencing where they ended up with medication. So it was whether the patients thought they needed the drugs was what pushed the clinician to give them drugs in some cases. And so the authors suggest that the expectation of medication, the belief that depression was an illness requiring treatment, needed to be actively addressed by clinicians in order to prevent over diagnosis and over medication of these people. So to summarize what I've said about antidepressants is there's no evidence that antidepressants correct an underlying biological abnormality. They alter normal brain chemistry and functioning in ways we don't fully understand. The evidence for their beneficial effects is minimal. They have generally under-researched because most studies don't go into long-term effects and don't look at negative effects with nearly the same attention as positive effects. They have underappreciated serious and common adverse effects with long-term use, including protracted withdrawal, that I'll talk about for another minute after this, and persistent sexual dysfunction. They most likely work by numbing people's normal emotions. The long-term outcomes are not very encouraging, and there is some evidence that they worsen outcomes compared to no treatment. I just want to briefly talk about withdrawal effects for 5 minutes, mostly to make a point about the guidance on long-term use of these drugs. So I've mentioned a lot of this in my last talk. I've already touched on it. Withdrawal effects are what happens when you stop a drug that your brain's got used to. It doesn't involve addiction. All you need is to use a drug for several weeks. Your brain adapts to it. When it misses it, you get withdrawal effects. An example that's relevant, I'm sure, to the audience is caffeine. You don't need to be abusing or addicted to caffeine. You just need to be using it to get withdrawal effects when you stop it. And the same is true for antidepressants. There's a very long list of withdrawal effects from antidepressants, including mood effects like low mood, anxiety, panic attacks, suicidality, as well as a whole lot of physical effects. Some of the effects can be very severe. People can become very agitated, very suicidal and coming off, even people that were not like that when they started the drugs. The longer you use an antidepressant, the more likely you are to get withdrawal effects. So a lot of the drug company studies are done after a few weeks when withdrawal effects are mild and brief, but we know that long-term users, you're much more likely to have withdrawal effects and much more likely for them to be severe and long-lasting, which is why there's such a disjoint between patients' experience and what guidelines have said for many years based on these short-term drug company studies. Often withdrawal effects are misdiagnosed as relapse. People turn up to clinic feeling panicked, anxious after stopping their drugs. And because all of us have been taught to focus on relapse, return of underlying conditions, people tend to jump to those diagnoses without exploring, could this be withdrawal effects, by looking at other symptoms, the timing of the symptoms, which can be very helpful to distinguish between withdrawal and relapse. This is a study in which we looked at protracted withdrawal syndromes. So I think there is a general recognition that withdrawal effects from antidepressants do occur, but I think a lot of clinicians still think it's a week or two of dizziness and headache, when in actual fact, for a proportion of people, maybe 1 in 7 people who come off antidepressants, there are protracted effects that can last for months or years, because the brain is affected by drugs in a way that can persist after stopping. And that might be why people get this post-SSRI sexual dysfunction. People have referred to this as being a bit akin to a brain injury, that people's brains are deeply affected by coming off the drugs. And so in this study, we asked people about the symptoms that they had when they stopped the drugs compared to what they had before they started antidepressants. And you can see that for every symptom we asked about, including being suicidal, brain zaps, sensory sensitivities, it was all greatly increased after stopping the drugs as compared to before starting them. In other words, this is not just a return of their underlying condition, but something else going on caused by coming off the drugs. And this is what I wanted to end on. The guidelines in Australia from the therapeutic guidelines or similar bodies suggest to continue antidepressants for 6 to 12 months for a single episode of depression and more than 2 years for people at risk of relapse, people with severe or recurrent conditions. This advice is actually based on stopping studies, what are called discontinuation studies that look like the diagram at the bottom. Depressed people who are given antidepressants and are improved are in these studies randomized to either stop their drugs or continue their drugs, and they're monitored with depression rating scales for several months afterwards. And when you put together all these studies, you find that the group that stopped their drugs, 40% relapse, whereas the group who stay on their drugs, a bit less than 20% relapse. And because of this difference, it's a halving of relative risk. This is why the guidelines recommend long-term treatment with antidepressants. But these studies have been criticized on a variety of grounds. Number one, people that respond to antidepressants is already a very selected group, but this is being extrapolated to all people that use antidepressants. But probably even more importantly is, in these studies, drugs are stopped very quickly, mostly in 1 day, mostly the average is 5 days. I haven't talked about it in this talk, but the guidelines in the UK now suggest people stop their drugs over months or longer. So this is very, very quick by modern standards. Stopping the drugs like that are going to cause withdrawal effects for a lot of people. That's going to increase anxiety, sleep problems, mood scores, which are all going to be registered on these depression rating scales that are used. In none of these studies are withdrawal effects separated from relapse. That means that this 40% relapse rate is going to be inflated by withdrawal effects being misclassified as relapse, which means the difference between these two groups is not going to be as great as these studies suggest that it is. And some researchers have argued that the entire difference between these two groups, this 20% difference, is explained by withdrawal effects. And if those were taken out, there would be no difference between these two groups. And so the implication is that actually these studies are showing that long-term use of antidepressants prevents antidepressant withdrawal rather than relapse. And I think I used the analogy last time. If you did this with smokers, took people who smoked, randomized them to stop smoking or continue smoking, and measured anxiety scores, and ignored withdrawal effects, you would conclude that people should continue smoking in order to prevent anxiety. Now, of course, cigarettes and antidepressants are not similar sorts of drugs, but the point is if you ignore withdrawal effects, you can come to some quite perverse conclusions about the relapse prevention properties of drugs. And so that is a major issue with these studies. And so it's not clear that there is good evidence for long-term use of antidepressants in people. This is a study showing that you get, when you cause withdrawal effects, you also get an increase in depression scores that would make, that makes what I said previously very plausible. A lot of what I've said before about how to stop the drugs is in this textbook that Leonie mentioned. The Maudsley Deprescribing Guidelines has been endorsed by the Royal College of GPs. It goes through how to stop these drugs safely using principles called hyperbolic tapering that I haven't had time to go into today. I'll stop there so there's a bit of time for questions. Thanks for listening.
Thank you very much. That was very interesting, Mark. So I just might start off the questions. So if we're not thinking about the disease model of depression, what's your opinion on people having supplements? So things like omega-3, some people I think were using, I can't pronounce it, it's SAMe. So a few of those things were kind of recommended as adjuncts or on their own. Vitamin D, seasonal affective disorder. Do you have an opinion on them?
I work a lot in America as well, and Americans are, that's sort of, the supplement industry is almost as big as the drug industry there. I guess what the data says is a lot of those things are probably safer than psychiatric drugs. A lot of those things, fish oil doesn't cause withdrawal effects, doesn't cause major sexual dysfunction. I don't know. Yes, what S-adenosine methyl something,
That
SAMe.
Yep. Yeah.
I don't know the safety data on that. So I guess the safety issues are less. I think the efficacy studies show quite similar effects. I think there was a study showing that fish oil has about the same effects of antidepressants in the short term. I guess if you were forced to choose between antidepressants and fish oil, that fish oil is a safer, similarly effective treatment. I do think that there's a bit of a danger. There's an implicit message in that there is a biochemical solution to people's problems. And I think that's mostly not what the data shows. But sometimes I think, are those sort of fancy placebos? I don't know the sort of proposed mechanisms, but I guess I got to say, to me, safety is more important than efficacy. If a child of mine was given an unsafe drug, I'd be extremely unhappy. If a child of mine was given an ineffective drug, I'd be less unhappy. So I guess when it comes to supplements, I think there is less concern about safety for most of them, because another issue with supplements is some of them are much more similar to psychiatric drugs than you would think. So St. John's wort is an obvious example. Everyone knows that. There's a whole lot of ones that are sold, GABA supplements, serotonin supplements, that are doing something a bit similar to benzodiazepines, a bit similar to antidepressants. Things like ashwagandha, there's a whole kind of, words that I can barely pronounce. Some of them have similar effects to Valium. They're GABA agonists. And so I've got to say, I sort of developed, when someone says to me, I've taken something and I feel very relaxed, I feel very calm, I sleep well, it makes me worried. Because, if something is I sort of feel like there's no such thing as a free lunch. If something makes you feel good, you're probably going to get tolerant to it. You're going to get withdrawal effects on the other side. So I've become very cautious, but I think, as I said, that the safety issues are less, and therefore it's a bit less worrisome.
Is that also how you feel about melatonin? People are taking melatonin kind of long term and say it helps with their sleep and depression and anxiety are kind of happy bedfellows.
It's a good question. I actually think less. I think there's less issue with melatonin. One, it is, it's I've never heard of withdrawal effects from melatonin. So I get thousands of emails a year from every drug you've ever heard of. I've never had an email about melatonin, so I don't think it has that issue. I think people, if they use low dose, it makes more sense. I think something like 10 milligrams before bed. It's not a great hypnotic. It's much better at setting circadian rhythms. So people who take doses like 0.3 milligrams a few hours before bed, it sort of sets circadian rhythms. So I do think that is less problematic than psychiatric drugs. So yes, I think that doesn't have the same issues.
And so following on from that, what about agomelatine, so valdoxin?
I mean, agomelatine, I guess it has that reputation of not causing withdrawal effects. A lot of studies, again, I've never heard about agomelatine causing withdrawal effects, so I think that's probably legitimate. I think I've searched on the internet, and on one Reddit page there were some people having some trouble, but it was obviously a minor signal. Um, obviously has major issues with liver toxicity. So you got to do these blood tests every 3 months. Its efficacy is the same as other antidepressants, that same 2-point difference at 8 weeks. So again, if you think about the safety side, yes, maybe it doesn't have withdrawal effects. I'm not sure the efficacy case is very strong, but and I guess the other safety, the liver issue is to me always pertinent. But withdrawal, yes, it does tend to be a much lower risk than other drugs.
So an audience member says, your talk focused on depression. Can you comment on the use of SSRIs in treatment of severe anxiety or OCD?
Right. So it's essentially copy and paste. I mean, I talk about depression because that's the most common diagnosis that antidepressants are prescribed for, but of course anxiety and OCD. OCD much less than anxiety and depression. Um, the studies are the same. So in anxiety, the difference between antidepressants and placebo is a very small number on the Hamilton anxiety score, so not Hamilton depression score. It's a few points. It's lower than what most people think is clinically important. All the same methodological issues with the studies also apply. There's publication bias, there's tolerance effects, there's unblinding effects. So all the same issues apply. Again, I think the drugs work in the same way. They don't solve people's underlying cause of anxiety. They probably work by numbing. That might be helpful in the short term. It can cause trouble in the long term. There are no long-term studies. All the anxiety studies go for 8 weeks, and that's similar for OCD. Studies go for 8 weeks. OCD is quite interesting in that there have been very good head-to-head studies of drugs and different psychotherapies. There's a meta-analysis in the Lancet Psychiatry looking at OCD treatment that shows that psychological treatments like ERP, extinction response prevention, where basically people are sort of trained not to respond with compulsions to their obsessions, has twice the effect of antidepressants at 8 weeks. So it's rare that there's been, often for depression therapy and antidepressants have a similar effect at 8 weeks, and people say, well, one's simpler than the other. Maybe we'll use antidepressants. But in OCD, that argument doesn't work because psychological therapies are much more effective than antidepressants after just a few weeks. But again, the same things apply. Antidepressants are probably numbing people's emotions and probably their thinking. And that's why people might get relief. And they often use, of course, they use higher doses in OCD. But all the same limitations to the studies apply. And of course, I should say all the kind of neurobiology I talked about, anxiety and OCD, there are no biological findings, there are no findings on neuroimaging, there's no biochemical findings. So people still, there is no brain-based explanation for what is going on. But of course, there's a lot of explanations from what's happening in people's lives, especially the developmental periods.
So going back to kind of add on from the supplements thing. So there's a lot of now it's TMS or transcranial stimulation. That's again, I guess, a disease-based approach to mental health. Do you have any opinion on that?
Yeah. So I'm glad I presented those few slides on the whole exactly disease-centered model versus drug-centered model. I guess, the kind of central theme that animates psychiatry is, how can we affect the brain to try to fix people's mental distress? We worked out how the heart works, and that's why we can, put in stents to people's coronary arteries and stop their having chest pain. You know, can we do the same thing with the brain? If we work out what bit of the brain to sort of press or shock or drug can we solve people's problems? I kind of think that has failed in psychiatry. You know, I think we have not found the brain-based causes of what causes mental health problems. There's a lot of psychological and social explanations that I sort of showed. And so I think a lot of the treatments that psychiatrists use um, disrupt the normal functioning of the brain. You know, that's sort of what the drug-centered model is doing. You know, alcohol helps people to feel less anxious by disrupting the way the brain works normally. You know, so you wouldn't say that alcohol is curative for anxiety. I think that's true for a lot of the treatments psychiatrists use, that drugs, you know, disrupt the normal functioning of the brain. That's what they can cause numbing or sedation or euphoria. And that includes magnets and electricity, you know, ECT or TMS, or these modern equivalents that imply either current, electrical current, or magnetic field to the brain, you know, cannot be fixing what causes depression or anxiety. They can only be disrupting. So if you look it up, put in TMS damage, you'll see a whole lot of stories of people who have been given TMS and have developed tinnitus or developed anxiety or worsened panic. And I think that's plausible when you think about, you know, magnets are not as strong as electrical currents. I think TMS is less disruptive than using a current, but you are doing something that is affecting the functioning of the normal brain. And so I think that brings with it inherent risks for injury, damage. So I've heard people say, you know, after TMS, I felt better. You know, people get these 40 sessions, huge numbers of sessions. They feel better. You know, the studies show similar things for antidepressants, very small effects at short-term time points. And I do think, you know, it's very hard to sort of knock the brain to solve people's life problems. So I think all of those physical interventions suffer from the same limitations as the chemicals that I've talked about today.
And what would your approach to bipolar disorder be, and bipolar depression?
Sure. Getting a bit beyond what I said I'll talk about here, but
Yes.
I guess I'll answer that, and it sort of comes down to the drug-centered versus disease-centered models. So there are lots of, when people are manic and they can't sleep, you know, and they're psychotic, there are lots of drugs that will sedate them or calm them down, and I think that can be very useful. You know, I'm not I'm not anti-drug. I think that you should be using drugs in a way that makes sense. So when people can't sleep, you know, I think giving people with a manic episode things that help them sleep is very important. If they can sleep, then things often recover. And that can be a variety of different treatments. It could be benzodiazepines, it could be antipsychotics, it could be mood stabilizers. But I think it's worth keeping in mind that none of those drugs are solving the underlying biochemical issue in bipolar disorder. And so they should be used for as short a time as possible, as at lower dose as possible. So in other words, I have a friend with very severe bipolar, and every couple of years she has a very severe episode, and she uses 6 weeks of antipsychotics to help her sleep and to calm things down, and then she stops the drugs. And she, you know, is a very high functioning academic. So I think the argument for long-term use of the drugs for prevention of relapse is not nearly as strong as the argument for the use in short-term symptom management. And I think, you know, if I could change one thought in doctors' minds, is the difference between something that suppresses symptoms versus something that modifies a disease. So I think in psychiatry, we have no disease-modifying drugs. We have drugs that sedate, that numb, that can stimulants, you know, can pep you up, but none of these things fix underlying conditions, and all of them wear off over time, tolerance. All of them cause withdrawal effects, and all of them have severe toxicities in the long term. So I think if I had to sort of summarize how to use the drugs, it would be short term, low dose, and doing everything else that's possible in the meantime, rather than the sort of drug heavy reliance that is kind of central to psychiatric treatment at the moment.
Wow, thank you. Yeah. I think there's time for one more question. So if anybody has one more question for Mark, this is really a privilege to have him here. So take advantage of it. And so I'm just going to say, so from your discussion about the natural history of depression,
Yeah.
really your approach is that depression is sometimes a prolonged adjustment disorder to a stressor. And so usually without my understanding of adjustment disorders is you can have chronic adjustment disorder or you can have an acute adjustment disorder, and there's a 6-month cutoff for that. And so if you have someone, for example, who's in a bad job, so they're exposed to their stressor chronically, they won't recover. So,
Yeah.
yeah.
So yes. So I guess the question is, does giving someone like that who is in a, maybe they're in a bad marriage, maybe they're in a bad job, does giving them a drug that numbs their emotions, that makes their sleep less restorative, that causes cognitive impairments, issues with memory and concentration, does that help them solve the issue? And I think, the research shows that it doesn't. So, I kind of get there's a lot of, I think I'm giving a very tough message to GPs because I know you guys are sitting there and you have a stream of people coming in with very difficult lives that you can't solve. You can't solve their bad job, their bad marriage, whatever it is, and you're left with very few tools. And you're being asked to, I don't know, deal with the sort of detritus of neoliberal capitalism with your prescribing pad. I think it's very difficult for GPs to be in that position. And you want to do something, doctors are taught to kind of be hands-on and do something and jump in, get their sleeves rolled up. And so, prescribing an antidepressant seems like, well, I can't help their job, can't help their marriage, but I can give them a medication. And I guess what I'm trying to say is, even if there's not therapy available, even if there is not some sort of wonderful holistic treatment, that doing something that's not harmful could be better. That's why I put in that slide about watchful waiting, that, 65% of people, if you do nothing, will get better. And I think that, even though of course the intention is very good, if you add to someone's issues with sleep, with sexual dysfunction, with emotional numbing, you may not be doing them a favor. Although of course that's your intention. So I think that the argument is, are antidepressants doing more harm than good, even for someone in a very difficult situation? And I think, to me, I think there's a lot of harm. There's not all that much benefit. And so I think even someone in an intractable, stressful situation like you're outlining, you may not be doing them a favor by adding on a drug that causes a whole lot of other trouble for them down the track.
So we've just got 2 more questions from the audience, if that's okay, Mark. So the first one is, and I was thinking about this as well, what about older people, say people with dementia or without dementia, with very severe agitated depression? What's your approach?
I mean, I'm not a specialist in older people, but it's for older people that the risks of these drugs are the greatest. So I didn't go into it here because I was covering a lot of ground, but there's studies in older people that antidepressants will increase their risk of falls, strokes, osteoporosis, cardiovascular disease, and an early death. And because, of course, these drugs cause postural hypotension, old people's liver and kidneys metabolize these drugs, less well. So there's a whole lot of, so all the physical health consequences are much inflated for older people. And of course, I should say in Australia, there's a huge prescribing in older people. I think, although 1 in 7 adults, I think when you go into the over 65, it's 1 in 4. And I think over 75, it's 1 in 3. So we have huge prescribing of antidepressants in older people. Again, the drivers of depression in older people, one of them is loneliness, a lot of grief in older people. So again, I'm not sure that antidepressants are the best solution to loneliness or to loss. Again, I think it's important to look at what the drivers of things are. Someone is saying agitated depression, and that's sort of, I guess the argument is that's a very biological event caused probably by vascular conditions or other processes. Again, I'm not sure of the evidence of whether antidepressants are more effective in agitated depression. I think that antidepressants are often used as a sedative, so things like mirtazapine, are used to sedate people. Again, I don't know the evidence whether the effect of the drug is highly effective and what the consequences are in terms of falls and fractures and things. So I think it's a difficult balance to come to. But at the moment we have huge levels of prescribing, and I'm not sure if that's warranted.
And our last question, if you don't mind, is or what antidepressant recommended for pregnant women generally?
So when it comes to pregnant women, there are no randomized controlled trials because it's considered unethical. So it's all extrapolated from other studies. As I've said, no antidepressant has ever shown a clinically important effect in depression. All those studies show 2-point differences that are less than what people consider to be clinically important. There's no reason to think that would be different for women. The studies that exist in pregnant women is when the drugs are stopped. So when drugs are stopped in pregnant women, they show that people that stop the drugs feel worse than people that stay on the drugs. And in those studies, the same as I've shown for depression, they don't measure withdrawal effects. So I would say that there's no robust evidence that antidepressants are effective in either postnatal depression or in depression during pregnancy. There is as I mentioned, there's a wide list of harms. These drugs in the first trimester, most SSRIs double or triple the rate of fetal abnormalities. They increase the risk that the child will get withdrawal effects when they stop their drugs. There's that's called the neonatal abstinence syndrome or the neonatal adaptation syndrome. So there's an argument made by some that sertraline is more effective or more safe, sorry, in terms of during pregnancy than other antidepressants. But I don't think that's a strong argument. So I don't think, antidepressants are cross the blood-brain barrier and affect the brain in adults. The same thing happens in the developing womb. We know that serotonin is a signaling molecule that's involved in development, and that animals that are exposed to antidepressants show all sorts of abnormalities in social and motor development. So I don't think that there is a safe antidepressant in pregnancy. There might be studies I'm not aware of showing that one drug is slightly less likely to cause developmental abnormalities than another one, but I don't think that there's any particularly safe drug in pregnancy.
Okay, right. Thank you. Thank you for all those messages, and thank you to everyone for sticking through. Oh dear, we've got. Have you got time for one more, Mark?
Sure.
This will be definitely the last question. So a lot of what you say is very opposite to what I've ever have ever encountered being done by psychiatrists when I, as a GP, refer patients to them for severe treatment-resistant depression. If the ultimate goal is to avoid medications, is there any benefit involving a psychiatrist at all? Oh, that's a good question.
Right. Let's get into it. I mean, look, in my psychiatry training, you are taught a very drug-heavy approach. I was taught that these drugs were very safe and effective and easy to stop. Based on all the studies that I've shown you, presented after 8 weeks. And psychiatrists, of course, want to help people, but they are taught, I think, a very skewed appraisal of the efficacy and safety data, and so they're very keen to use medications. And so it's been mentioned severe treatment resistance. I think that's really worth focusing on. I've shown you that the antidepressants are not very effective, so they don't work for most people. Treatment resistance is defined as people who don't respond to 2 antidepressants. That's a very large group of people, because if the antidepressants are not that effective, then people who fail 2 is a lot. And so you can quickly escalate. If you take someone whose problem is loneliness or a bad marriage, give them an antidepressant, it doesn't work very well. Try a second antidepressant, doesn't work very well. You very quickly get into, now let's try ketamine, let's try doubling the dose, let's add in a mood stabilizer. You can very quickly go down a kind of very medicalized route, where a social problem, a life stressor, is now turned into multiple medications. Medications cause side effects, which led to more medications, a prescription cascade. So I think there is a real risk to using a kind of biomedical, pharmaceuticalized model when it comes to treating people's low mood. So I think there are risks to going down that psychiatric route, definitely. I know, for example, in England, a few GPs came out and said, we don't send our patients to pain clinics anymore, because when they go to pain clinics, they come back, rattling with medication, which we can never stop because it's difficult to get off. And so some GPs said we don't send people to pain clinics anymore. And I think for some people that may also apply to psychiatric clinics.
Controversial. Thank you. Okay, thank you everyone for attending, and thank you so much, Mark, for talking with us again. That was really useful. We're going to put the recording up on the Capital Health Network YouTube page, so I'm sure people might want to dip in and watch a bit again, or share it with other people. And a lot of food for thought there. Just to reiterate, please complete your evaluation surveys so we know what other events to host, and also please self-report 1.5 hours of educational activities to your CPD home. And that's it for tonight. And thank you for being so generous with your time and answering the multitude of questions.
Thanks for having me.
Thanks very much. Bye.